And with this, I'd like to introduce our next speaker, Dr. Christine Kiire, who's going to be talking to us on subliminal laser for non-centered DME. Christine, take it away.
So I'd like to talk to you about subliminal laser therapy for predominantly non-center involving diabetic macular edema. My name is Christine Kiire and I work at the Oxford Eye Hospital. Just trying to proceed to the next slide. There's limited real-world data that's been published on the effectiveness of subthreshold macular laser treatment for diabetic macular edema, particularly within a National Health Service context in the United Kingdom. Oxford was an early adopter of this form of laser treatment for patients with diabetic macular edema. And with the introduction of anti-VEGF injections for center-involving diabetic macular edema for patients with a central retinal thickness of over 400 microns in England in 2013, laser treatment became the main form of treatment for predominantly off-center clinically significant diabetic macular edema. The ways in which central retinal thickness of over 400 microns was interpreted varied from site to site, but in Oxford we took that to mean the central subfield thickness being greater than 400 microns. We therefore decided to review the outcomes of our subthreshold macular laser treatments performed between 2013 and 2018 for predominantly non-center involving diabetic macular edema. We had three specific questions in mind. The first leads to our primary outcome, and we were interested in what the effect of this subthreshold or subliminal macular laser therapy would be on visual acuity, macular volume, and central subfield thickness in the short term in eyes of patients with predominantly non-center involving diabetic macular edema. So we wanted to compare their baseline values with values at their first follow-up visit that was taking place 5 to 10 months after the laser treatment had been performed. As secondary outcomes, we were also interested in the proportion of eyes that were having subthreshold or subliminal macular laser treatment performed more than once. We were also interested in the proportion of eyes that had had this form of treatment for non-center involving diabetic macular edema that progressed to requiring treatment with intravitreal injections for center involving diabetic macular edema because they'd met the treatment threshold. This was a retrospective analysis conducted at the Oxford Eye Hospital. Our participants were adults with diabetes who had an electronic medical record entry of at least one eye having received subthreshold macular laser treatment for non-center involving diabetic macular edema for the first time between January 2013 and September 2017. We excluded any eyes with any other pathology that might account for the macular edema, for instance, a retinal vein occlusion or pseudophakic macular edema or uveitis. We also excluded patients who had had cataract surgery or PRP laser, either in the 6 months before their first laser treatment or between their baseline treatment and their first follow-up visit in that 5 to 10 month window. Patients with glaucoma were excluded because this can affect visual acuity. We collected data on the patient demographics. Visual acuity was measured using the patient's usual spectacles, and we defined stable visual acuity as a change of less than 0.1 logMAR units. The macular volume of interest was the central 3 millimeters of the macula, as easily measured on an ETDRS grid. Central subfield thickness was, as most people understand, the average retinal thickness in the central 1 millimeter of the macula. Our glycated hemoglobin results were included if they were within 3 months of the baseline laser treatment, and we recorded data on the type of laser machine that was used. The sources of our data were essentially the patient's notes, and the OCT machine that was used was the Spectralis from Heidelberg. We used a generalized estimating equations approach to assess the change in vision, macular volume, and central subfield thickness from baseline to that first follow-up visit, and we assessed whether our results varied when adjusted for potential confounders. These include HbA1c and baseline values. For our secondary outcomes, we were just calculating percentages of participants, and I'll explain a little bit more about that in the results section. So when we did our search for potential participants, we identified 364 eyes of 292 patients. Now, this was from the electronic records, and we had a hybrid system of paper and electronic records. So we then scrutinized the records to check if patients were eligible for inclusion in our analysis. And we found that 72 eyes were not eligible for inclusion because we discovered that they had comorbidities of relevance or that they had treatments that were maybe documented on paper and not in their electronic records. This left us with 292 eyes, of which 79 eyes did not have any follow-up in that 5 to 10 month window after the laser treatment, and so those eyes were excluded from our analyses. We were left with 213 eyes, of which 11 had inadequate OCT imaging, and therefore we analysed 202 eyes from 156 patients. Just over half of these patients were male, with a mean age of 65 years, and an HbA1c result within 3 months was available for 3/4 of the patients. On average, the HbA1c level was 7.9%, which means that the patients had reasonably good control compared to some others. Most of the laser treatments were done with a yellow laser from the SuperScan or EasyRet laser in subliminal mode, but a quarter of the patients, or just over a quarter, were treated with an Iridex 810 nanometer laser, which is conducted in a different way. The patients do not have the laser titrated to their own personal response with that particular laser. Our baseline logMAR visual acuity was 0.148, and the baseline macular volume was on average 2.5 cubic millimeters, and central subfield thickness was 317 microns. The median interval between the baseline treatment and the first follow-up visit within that 5 to 10 month window was 7 months. And so whenever I'm mentioning that follow-up visit, it's at approximately 7 months after the baseline treatment on average. So if we move on to our primary outcome, we can see that from baseline to that first follow-up visit, there was no statistically significant change in the patient's visual acuity. But there was a statistically significant change in the patient's macular volume in that central 3 millimeters and in the central subfield thickness. We found that there was a very small increase in macular volume, an increase of 0.05 cubic millimeters, and the central subfield thickness rose by 14 microns. And that led us to really question whether those tiny increases in macular volume and central subfield thickness would really be of clinical relevance given the magnitude of them. They seemed very small and they didn't seem to have an impact on the patient's visual acuity. When we looked at stability of vision using the definition already described, we found that 76% of patients had stable visual acuity, 11% had an improvement in their vision, and 12% seemed to have a deterioration in their vision. Adjusting the model for HbA1c and baseline values did not significantly alter the results. And this is another way of illustrating the data. On this figure, you have baseline values on the x-axis and the 5 to 10 month outcomes on the y-axis. And you can see that there's a diagonal line, which is essentially a line of no change from baseline to the first follow-up visit. And most of our data points are hugging that line, meaning that there is general stability overall. For baseline subfield thickness, there were some patients who started out with a thinner retina who went on to have thickening of the retina. And because we didn't treat over the foveal avascular zone, it led us to wonder whether the fluid was being displaced from the area that was being treated, perhaps towards the center in some of those cases. In terms of secondary outcomes, we were interested primarily in additional treatment following that initial baseline treatment. And we found that by January 2020, which was the last point at which we reviewed the outcomes of these eyes before the coronavirus outbreak, 60% of the patients had received additional treatment of some form beyond their baseline first treatment with subliminal subthreshold macular laser. Now, because some of the patients will have had treatment as far back as 2013, and some of them will have had treatment closer to 2018, the length of follow-up of the patients was not entirely uniform, but we thought it was interesting that 60% of patients needed something else done at some point in the future. Similarly, by January 2020, 44% of eyes had had laser performed more than once overall. That's about 2/5 of the patients. The laser treatment was repeated for the same area of thickening at or before that first follow-up visit in just 27 eyes, so 13% of eyes. So there were patients who were having new areas of retinal thickening that were treated as well. Now, by January 2020, we looked at patients who had more laser after that first follow-up visit in the 5 to 10 month window, and 37 of them had received further laser after that time. And 30 eyes, 15% received both additional laser and intravitreal injections, again, after that first follow-up visit. And in total, it seemed that the proportion of patients who went on to receive intravitreal injections after that first follow-up visit was, by January 2020, almost a third of the patients, just below a third. And the majority of these received treatment with intravitreal anti-VEGF injections. So to answer the key questions that we posed at the beginning, it looks as if with this subliminal or subthreshold macular laser treatment for predominantly non-center involving diabetic macular edema, 88% of our patients achieved stable or improved vision, but overall there was no significant change in their visual acuity. It's true that there were statistically significant increases in their macular volume and central subfield thickness, but these were very small, and we need to consider carefully whether or not these were clinically meaningful, particularly given that there was no associated significant reduction in the patient's vision. The proportion of eyes that had laser performed more than once by the point of our last review before the COVID pandemic hit looked like it was about 2/5 of the patients who needed treatment more than once. And the laser treatment was repeated for the same area of thickening within that 0 to 7 month period on average in 13% of patients. In terms of the proportion of eyes that progressed to having treatment with intravitreal injections, well, we had excluded any patients who had an intravitreal injection before that first follow-up visit, but there were only 20 eyes in that category, but out of over 200 patients. But when we look at those who went on to have injections afterwards from whatever date their baseline treatment was to that first follow-up visit and then on to January 2020, just under a third of patients progressed to having treatment with intravitreal injections. It's always worthwhile commenting on potential sources of bias. The time point of interest to us was 5 to 10 months after the initial treatment, but we work in a teaching hospital where doctors are rotating through often on 6-month rotations, and some of them will have wanted to follow up their own patients within that time frame, and might have seen patients, for instance, at 3 or 4 months after the laser treatment. And if they were happy with what they saw, they maybe would have given them a follow-up appointment beyond the 10-month window, particularly if the patient was doing well. And so that may introduce a potential source of bias. Also, we had 3 different laser machines that might have different levels of effectiveness. We're talking about 2 different wavelengths of laser light and 2 laser machines where in subliminal mode, we are titrating the laser compared to the Iridex 810 laser, where it was a one-size-fits-all sort of treatment. And of course, there's a learning curve for laser operators, particularly in a busy teaching hospital like the one we work in, with a high turnover of junior doctors. To our credit, this is real-world data with relatively high numbers of patients when compared to published data sets, so I think that's a strength of this data set. Other limitations that we've considered are the fact that because we had this chosen time window of 5 to 10 months after laser treatment for our primary outcome, we will have lost some data from those 75 eyes, and there are different ways of examining the data that might allow us to incorporate more of our results overall. Visual acuity was best corrected in terms of the patients using their usual glasses, but we didn't refract the patients to get their true best corrected visual acuity, and their logMAR vision was sometimes converted from Snellen acuities. Also, the subjective nature of the decision to retreat with more laser or to observe a patient or potentially give them injections is a limitation of a study like this, just by the very nature of it. In terms of potential further work that can be done, we're interested in separating out the outcomes of the different laser machines, or at least specifically just looking at the yellow 577 lasers, since those are the main lasers that we use at the moment. A more detailed evaluation of the changes in vision and macular volume, as well as central subfield thickness over a longer time frame that incorporates all the data we have, regardless of whether or not it fits into a pre-specified time window, may be informative. We could look at how these variables have changed over 12 months or 24 months, and that would allow us to incorporate more of our results overall. We're interested in assessing the shift in the area of retinal thickening in order to understand whether the laser might be displacing the fluid in some situations. And I think that in light of Protocol V results from the DRCR net, I think it's worthwhile considering the option of a randomized controlled trial of observation only versus subthreshold macular laser for this particular cohort of patients with predominantly non-center involving diabetic macular edema, perhaps up to 24 months as they did with Protocol V. And we eagerly await the result of the DIAMOND study, which was conducted using a different iridex laser, 577 nanometer laser, in which they were comparing subthreshold laser, they call it micropulse laser, with conventional continuous wave laser. And hopefully those results will be available to us to help us understand laser for diabetic macular edema a bit better shortly. Thank you very much for your attention. I'd like to acknowledge my colleagues, all of whom contributed to this work.
Thank you, Christine, for an enlightening talk